How much of that plays into your practice dealing with obesity medicine?
Yep, great question. And I think this brings in the part about when you think about this specialty, you want someone going into this who is very much committed to
Dr. Jessica Bartfield, how are you doing, my friend?
I'm well, thanks. How are you?
I'm excited. I'm great. I'm excited to be chatting with you on this wonderful MLK Monday about obesity medicine, something that is very important to talk about. The U.S. Leads the way. We're number one typically when we talk about obesity in the world. And it's something that not a lot of people know that it's its own specialty out there. And I think no matter what specialty you go into, it's going to play a part of in your specialty. So I'm excited to chat with you about obesity medicine. The question that we love here at eShadowing is, what is bread and butter for an obesity medicine specialist?
Yeah. So I think the bread and butter is kind of what you touched upon. So really, in my training, so internal medicine training, and even, kind of preclinical years, med school years, the problem list, you learn to develop a problem list, right, when you have patient care. And so on the problem list, I kept seeing a recurring theme amongst all the other issues that patients would face. There would be this term obesity, and it was tend to be listed near the bottom of the list. And yet it seemed to connect to almost every other problem on the list. And so this is a pretty new field in the idea of, can we do a much better job at weight management, at helping our patients lose weight, prevent weight gain, maintain weight loss, and therefore reduce the risk of disease of multiple other issues. So when I think of kind of bread and butter, I think of obesity medicine as, again, almost one of that internal medicine specialty, meaning head to toe, every single organ system can be negatively affected by excess weight. Over 200 diseases have now been connected to excess weight, some directly caused by the excess weight, some just made worse by excess weight. But essentially, it's that idea of really knowing essentially all of the body to some extent. And in terms of treatment, it's the idea of kind of empowering patients, prevention of disease, lifelong relationships, longitudinal care, chronic disease management. Those, I think, are the real ways to think about obesity medicine for someone interested in the field.
What's the biggest misconception about obesity medicine or obesity in general? So
I think the biggest misconception is just the idea that it's not a disease and that it can be cured. And what we've demonstrated, this field has had tremendous growth even in the past 10, 20 years. And what we found as through science and kind of through better research and better understanding is that the adipose tissue itself, fat cells, are more of like an endocrine gland, meaning that they don't just store energy. They're not just kind of, inert or kind of what we previously thought, but they're actually active and lead to a cascade of other diseases. And yet at the same time, I think we hear the same message of just diet and exercise, eat less, move more, eat less, move more. And the idea that people can almost make this choice, right, to kind of manage their weight, and that people try to make it very simple when we know that it's very complex. There's multiple etiologies. It's not just how people eat. It's not just their activity, and that it is a chronic disease. So meaning that, yes, when they lose weight, they're not done. They're not, they kind of don't shake their hand and say, okay, Godspeed. It's this idea that you really want to be continuing care, true at different approaches, and it might be a different type of care with weight loss maintenance than active weight loss. But it's the idea of the complexity and the chronicity, I think, are still very much underappreciated for this field.
It's funny when you mentioned, right, that it's kind of this own endocrine gland. I picture kind of like this parasite that's setting up shop going, okay, we're here. We don't want to leave. What do we need to do to stay? oh, let's make our human hungry all the time for the worst types of foods. And it's just, I get that picture in my head, and it's kind of true and kind of a little hyperbolic, but it's interesting to think about it in that way.
Yeah, absolutely. And I think that's, again, what's fascinating about this is the idea that so when we talk about obesity treatments, we try to talk about behavior modification being down the foundation of anything else you do, whether it be medications for weight management, whether it be surgery, whether it be devices. The foundation is behavior modification. And so modifiable, right? Things you can change in your behavior. And we focus on ones that impact weight. So eating, activity, sleep, stress. And yet, even within those, so your example is the appetite, our appetite regulation, the central signals in the brain, the signals from your peripheral organs, from your gut, from your liver, from your skeletal muscle, and then all the environmental influences we have on our eating. It's not really something that we have very much control over, or there's at least a lot of forces that we do have to kind of face and manage in order to make those kind of behavior changes. So and we've got great hormones, ghrelin, the hunger hormone, telling our bodies exactly that. And then we have some hormones, we have more hormones telling and signals telling our bodies to eat than we do that shut it down. But there is a balance that does get dysregulated and then makes people vulnerable to excess weight gain.
Yeah. The more that we have learned about childhood adverse events and the ACEs score, how much of that plays into your practice dealing with obesity medicine?
Yep, great question. And I think this brings in the part about when you think about this specialty, you want someone going into this who is very much committed to the behavior and the psychology piece of all of this, because we know that about 30% of patients with severe obesity, so severe obesity is defined typically as BMIs greater than 40 or above, 50, 60, 70. And patients with severe obesity, about a third of those have suffered some type of adverse event as a child. Most common being sexual abuse, but still it could be any other types of abuse. It could be trauma themselves. It could be just, witnessing trauma. It could be, significant kind of difficulties in terms of the social determinants of health, socioeconomic status, things like that, food deserts, food scarcity things. So it does play a role. And especially when we look at the childhood rates of obesity, which unfortunately are not doing any better than the adult rates, we're still at right about 20% of children with obesity in the United States. And so the idea of, can we do better prevention of that or earlier treatment? Because just like any disease, the greater the duration, the harder to treat, the more risks associated with it, and the more severe it typically gets.
Yeah. What's the training path look like to be you?
Yeah. So I'm going to share some of the slides.
Yeah, let's do it.
If I can here. Okay. Is that working?
Yep.
Okay. So just to kind of go back a little bit, I know we threw the term out there pretty early, but just to make sure everyone is on the same page about the definition, because this term actually hasn't been around for that long. But if you look at certain resources of what is obesity, so you go to something like Britannica encyclopedias, it's essentially just describing this, excess fatness, accumulation of body fat, consumption of more calories than the body can use. If you look at the Obesity Medicine Association, which is a great society that actually offers some really good educational tools and resources for obesity medicine, they describe it more to what experts in the field view it as. So again, chronic, relapsing, multifactorial, the neurobehavioral disease, where you have this excess of body fat increase and then the adipose tissue dysfunction resulting in other diseases and the different categories of those diseases. And then essentially you define it, World Health Organization and the CDC, essentially by the body mass index, which is just a calculation. And it's, really your weight in kilograms divided by your height in meters square. So there's a lot of flaws with the BMI, and experts in the field, including myself, actually tend to hate the body mass index because it tells us so little, and it actually is very low utility in predicting risk and disease. But it's easily done clinically. It's easy to use for studies, particularly for epidemiology studies, population studies, things like that. So looking at the body mass index categories, you have your underweight less than 18.5, healthy weight is right up into the body mass index of 25. Overweight is 25 to right under 30, which, by the way, was kind of shifted lower by the World Health Organization back in the late 90s. And so again, that if you move the target, right, you're going to widen that net of capture. And so that obviously increased rates of adults with overweight status. And then obesity is defined as a body mass index over 30, and then again, severe obesity over 40. And this is data from the NHANES, and this just kind of breaks down where we are in terms of men and women, and then breaks down by race and Hispanic origin. And this was the most recent data. The next cycle is due out probably actually now, because they do it every 2 years. But as you can see, the rates are right around, for most groups, right around 40%, and have climbed increased by about a third over the past 20 years. And what's more concerning is that the rates of severe obesity have increased by really almost doubled over the past 20 years. And this is, again, why we care in terms of head to toe, every single organ system negatively affected by the excess weight.
Do we have any? I'll jump in and ask a question that kind of came from a student, kind of correlated with potentially that big jump in the severe obesity. Do we have any correlation with anything in terms of potentially how food is manufactured, how like we're adding hormones to everything to grow things faster so we can get stuff processed and manufactured faster? Do we have any clues as to why that is happening so fast?
Yeah, awesome question. And I think that the answer, again, is multifactorial. So they haven't identified just one thing. They have identified multiple things. So, and there is some nice kind of graphs even on the CDC and resources to kind of look at the evolution of what I call kind of our eating patterns. We don't really have a food culture. And if we do, the best way to describe it is, I almost call it like it's got, kind of personality disorder. It keeps changing. And, we seem to jump from one thing to one thing every year. So if you look, first of all, at, so obesity is a dysfunction, and it's an energy imbalance, right? So your energy intake tends to exceed your energy expenditure, and that leads to weight gain. So if we look at the two sides of that, the energy intake and then the energy expenditure, when you look at the energy intake size, there's been clear increases in standard portions of nearly everything. They've got some pretty interesting pictures of just something like a bagel and how that size has increased. A plate of spaghetti that you would eat out at a restaurant, how much that's increased. The idea of like supersizing meals. I mean, if you think about that, at McDonald's, when it first opened, it was, kind of single size hamburgers, small fries, everything the same. There wasn't these giant, supersize and triple and king burgers and things like that. So that's been a clear increase. The fountain drinks, the sodas that are sold. And to your point about kind of the idea of this almost like manufacturing of food, I mean, the food companies are smart. They know what sells. And so they hire food scientists. I mean, that's just some of their jobs. I actually knew someone from Domino's, and their job was to kind of create these tastes that were incredibly palatable. And that we know kind of lead to overeating and lead to, changes in dopamine, serotonin. And so can make it that much more appealing and that much more easier to overeat and harder to kind of, push away. Cost of food. So when you look at kind of the cost of different types of foods, we know that things that are, fruits and vegetables, especially fresh produce, much higher cost than Oreos or Doritos or, the dollar menu, things like that. The number of fast food restaurants has increased tremendously. And when the amount that's being sold at each one, so what used to take 8 months, the number of hamburgers that used to take McDonald's 8 months to sell, it now sells within a matter of, like 5 weeks. So it's just a tremendous increase in this energy intake and what we call it energy density. So foods that are very high in calories, and they don't even have to be very large portions. They mostly are, but they don't even have to be because they're such high energy density. There's just high calories even in a smaller amount. And then you look at the energy expenditure side. And again, particularly, I think this is some of what we're seeing, data coming out of just even with the pandemic restrictions and people losing just even that daily activity because their commute now all of a sudden might be a few steps from their bed to their desk, or, maybe upstairs to downstairs or one room to another, working from home and not even having kind of those extra daily steps in. But our sedentary behavior has just skyrocketed when you look at, within a generation. So we're not talking 100 years ago, we're talking 30 years ago, 40 years ago. There's just been that much change. And there's other factors. There's thoughts about interuterine influences, so things that occur in the womb and kind of then how do they play out in environmental effects. Certainly, there's been thoughts about not necessarily just even antibiotic use in animals and growth hormones in animals that then we've consumed that food, but just antibody use in humans. And what does that do to the gut microbiome? And then can that influence risk of obesity? Kind of some of this epigenetic level causes and vulnerability. So multifactorial, pretty complex.
Yeah. Yeah, it's interesting. One of my best friends from med school is a microbiome GI doc at MGH, and it's just the things that we're starting to learn about microbiome. It's just like, when are antibiotics going to end up on the controlled substance list so that doctors can't hand them out like candy? Because it's crazy.
Yeah. And they've done some cool things. They did a fecal transplant in mice with, genetically kind of knocked out for obesity and mice that were lean, and did a fecal transplant and proved that, there's definitely a role in gut because the mice that received the feces from the obese mice, gained weight. So I think a lot of cool stuff coming down the pipeline. Nothing in treatment yet, but I have no doubt there will be at some point.
Yeah. One of the biggest things that we're running into in our society specifically, especially right now with COVID, is this pushback on big pharma that's always been there, but is just peaking right now because it's like, you want me to get the vaccine, it's experimental. Let's ignore the fact that they're running to the hospital getting experimental drugs for treatment when they get COVID. But there's this big pushback against science, against doctors, and we see as your charts show, there's a lot of patients out there with who are overweight, who are obese, and for the pharmaceutical industry, that's like, oh, big dollars because there's lots of patients to treat versus some rare disease, which in my mind is going to lead to further pushback from patients on top of what has been this increasing body positivity movement, which a student brought up in the chat. Where can we, as science educators, educating patients, help them understand that we don't want to treat you to make money. We want to treat you so you're healthy. And yes, body positivity is great, and obesity is bad for you.
Yeah. So I think that's a really important point, really important. And this is why I hate the body mass index, because patients will be, you're probably going to identify at least 30% of the patients who would be, kind of in the obese category, right? And like STERM to have obesity, no issues. Completely metabolically healthy. And it might not be that they even have a higher, muscle mass. It just might be their numbers look good. And so why are we being so aggressive? And why does a, preventive task force say, oh, they all need intensive behavior treatment? No, they don't. I think they need it if they're facing risk of health issues. Yeah. So I think that's the number one problem, is the way we just even talk about this and saying, oh, you hit this again, number. You have a disease, right? When that's not how experts in the field views this. We view it as, okay, I think the most important thing is actually the delta, right? The change. So if your BMI is 34, but hey, guess what? 6 years ago, your BMI was 40, you're doing great. And I don't, we need to just focus on kind of managing weight, healthy behaviors, all that good stuff, and keep an eye on all the other numbers that we kind of really utilize to assess risk of disease. But if your BMI is 28 and 3 years ago it was 25, okay, we might need to talk about what's going on, or even a year ago, is something changed in your behaviors? How is your nutrition? How is your sleep? How is your stress? Are you getting exercise in? Are you just getting steps in during the day? So that's what I think. I actually think that healthy at every size, because they do promote health, right? That's the first word in that. So I think there's actually way more overlap than the if you say the two groups kind of, then they realize. And so I think it should absolutely be this idea of assessing multiple different factors to truly determine health.
What you're saying, the term that I've heard a bunch that we use typically in the doctor world is you treat the patient, not the number, right? Not the scan, not the whatever. You treat the patient in front of you. So
absolutely. And on the point with the medications, what's interesting is there is still actually a lot of bias against weight loss medications. We're getting better, and we do have more, really promising ones. One that was just
bias from physicians or from patients.
So bias from physicians, patients, and even the FDA. Okay. So, in terms of having to come to fruition, right? In terms of having to be approved by the FDA, which I think is very important, because if you look at the history of different medications and different therapies used for weight management, it's not that great. So I can appreciate where the bias comes from and maybe where some of the wariness comes from. But the idea of some of these other medications that we used all the time don't face the same kind of criteria and regulations and necessities in order to be utilized. Yeah. And if you look at bias with providers, in terms of prescribing these medications, out of the patients that meet criteria for using it, and again, you can say, well, that's just going by the numbers. Only about 2 to 3% of patients who meet criteria for weight loss medications actually receive them. And if you compare that to another chronic disease, something like high blood pressure or something like diabetes, in diabetes, 85% of patients that are meeting criteria for medications are receiving it. I think we don't even hesitate to think about treating diabetes, high blood pressure, cholesterol difficulties with medications. And yet there's just this hesitancy with weight loss medications. Yet weight loss supplements, which have no regulation, is nearly, is a $20 billion industry, and 20% of patients will use those on their own without any medical guidance, and there could be real risk to those. So I think these are some of the conversations that, people need to consider and probably need to be having with their patients.
Yeah. All right. Let's keep rocking. What else you got for us here?
Okay. So this just goes through the treatments in terms of, again, start everything with behavior lifestyle modification, add on more intensive options like pharmacotherapy or bariatric surgery as needed, and that the treatment is indefinite. Targeted strategies, multiple approaches. So that's the problem with really, referring patients to, or even providers saying, hey, this is what I would recommend, right? This is what helped me, is the idea of you can't do a one size fits all. You can't kind of give the same treatment to anyone who walks through the door and when looking for weight management, right? It's very different than treating pneumonia or treating other things where we have clear kind of, these are the medications you use, this is the approach that you do. So targeted treatments, multiple strategies, and that indefinite treatment. So obesity medicine, kind of get back to the original question, it's exactly what it kind of is the term is. It's a specialty that really looks at treating patients with complicated obesity. So again, that's what kind of sets us apart in terms of, okay, not just anyone with obesity, but someone with more complicated obesity. And what does that mean, complicated? So people who've had a history of difficulty losing weight, some of these people who have had lifelong challenges with weight management, multiple episodes of weight cycling, or just not good response to treatment. Maybe they lose, 5, 10, 20 pounds max when they're really needing to lose more to kind of have some significant health benefits. Patients with multiple medical issues, so they might even have a low BMI, but if they have multiple medical issues, they're going to be more complicated. Patients that are on medications, we know that about 10% of patients with obesity, it's caused by iatrogenic, so medications that we're prescribing to our patients for other reasons that increase weight gain. People with more severe disease severity, so higher BMIs, this says 35, but probably the average body mass index that I manage in my practice is, well over 40, 45. So that's severe obesity. And then again, higher risk factors. So they may not have active disease, but they might be on that pathway, kind of pre-diabetes, insulin resistance, they're starting to show some signs, or they may have significant family history, or for women, gestational diabetes, where we know that they're at higher risk, and that weight management really influences that risk. And then there's an entire population, because of the concerns that patients with obesity, severe obesity, face with certain procedures, they need to lose weight to actually receive medical care. So this is the most common example is joint replacement. So body mass index threshold for joint replacements is 40. So most orthopedic surgeons do not want to touch a patient until that body mass index is 40 or less. But this also goes for, a lot of the robotic procedures. Sometimes women undergoing IVF need to lose weight prior to that kind of pathway in that treatment. So that's a very specific population that we tend to help as well. So the path to this career is, again, I put a training in like a residency training in internal medicine or family medicine, just because that's the most common. And most fellowship programs, obesity medicine fellowships, that's the candidates that they're looking for with that type of training background. Now, that being said, there are plenty of, I do an elective for fourth year medical students. And so there's plenty of students going into all different specialties who do our rotation and our elective to get that deeper dive. Because as you said at the very beginning, this affects any field you go into. You're going to be managing patients with obesity, not treating them, but you're going to be certainly caring for them. So that's the most common, but I have, there are specialists who maybe have a certainly pediatric background, certainly OB-GYN. There are even some psychiatrists that have, gone into obesity medicine. After you do your residency training, then there are two different pathways to board certification. So I highlighted the obesity medicine fellowship pathway, and I'm a little biased. I'm the director of our obesity medicine fellowship at Wake, but I do think this is the best way to train for a career specifically dedicated to this field, where if this is what you want to do and you are interested and passionate and you want to kind of really have this be the majority of your career, do a fellowship. You need that clinical training. It is very different than just obtaining kind of the CME credit hours that you have to meet in order to take the board. We are now up to 20 fellowships across the United States. They're typically a year long. They're not accredited yet by the ACGME, but we're on that pathway to get them accredited, and we hope to be able to soon. So this website, the Obesity Medicine Fellowship Council, if you go to their website, they have past fellows, what they're doing now, different career opportunities, job opportunities, how to apply for a fellowship, what the different fellowships are, where they're located, who the different council members are, and the different fellowship directors. So really, really encourage anyone with an interest in this field to do a fellowship, because I think it's a very rich type of training that will absolutely separate you into that expert level in this field. And it's still a small field, which is great, because then there's a lot of networking opportunities, a lot of support, a lot of resources, and a lot of opportunity, and not just clinical care, policy, academia. There was some docs will go on and do things with industry. So plenty of opportunity. Or you could do the CME pathway, which again, then you have to accrue a certain number of CME credits in order to sit for the American Board of Obesity Medicine, which continues to grow every year. They offer it once a year. And so the number of physicians taking this continues to grow, which is great. So that's kind of the pathway to a career in obesity medicine.
Awesome. You mentioned you have some case studies. I'd love to jump into those.
Yeah, absolutely. So I kind of did two different ones. So one, I wanted to walk through more of like an assessment. So if you were sitting in clinic with me, kind of what would we go through with a patient who comes in specifically for weight management? And then we'll go through one that deals more with treatment. So I guess best way to do this is if, people want to offer in the chat, kind of, go ahead of me as I kind of say these questions, I'll pause and then give the answers. But certainly, Ryan, I guess if anyone can get on, just let me know and I'll pause.
Yeah, let's do this one. You mentioned this one is less
walkthrough.
Walkthrough. Yeah. So let's do this one with the chat.
Okay.
That's great.
So, so sitting in clinic with me, and we have a 35-year-old Mexican-American female who's interested in losing weight. She has a strong family history of obesity. So when you ask her about kind of family history, if anyone else in the family struggles, she said, yes, my mom, my father, and then even my mom's sisters and my grandmother, all with pretty severe obesity. She herself has noticed that she's gained about 15 pounds after starting a new job a couple of years ago. She's tried some things on her own. She did Weight Watchers for about 3-4 months, maybe lost about 7 pounds, but, kind of regained it pretty quickly, getting pretty frustrated as she hasn't had any good treatment response. So taking a kind of a weight history, we learn our basic components of the history in terms of, family history, social history, medications, past medical history, past surgical history. So yeah, that's all standard. But when you are going in and treating a patient for weight management, you want to get into a little bit more depth. So most common people say, oh, I take a dietary history. Yes, but within that dietary history, you're not just asking for a 24-hour recall. You're asking about timing of meals. You might say, majority of your meals prepared at home or, outside of the home. How many times out do you eat a week? How many meals do you eat a day? Do you tend to skip meals? Do you tend to snack? What time do you snack? If you do snack, are there certain foods that you gravitate towards? What do you drink throughout the day? And that, you tend to try to give them specific examples. They may say, oh, water or soda, but you want to try to quantify it. Okay, well, when you have a soda, is it a can? Is it a bottle? Is it a fountain drink? When you say, coffee drinks, do you put anything in the coffee? Alcohol, any kind of sugar sweetened beverages. So not just juices, but juices, lemonade, sweet tea, Gatorade, sodas, obviously. And then in terms of the eating patterns, night eating syndrome is something that I think is very overlooked and actually way more common. We're just not necessarily picking up on it. So that's what is the timing of the meals, meaning do most of your calories come at the end of the night? Do you feel like you have significant cravings? Do you have difficulty feeling full? Or are you hungry within an hour of eating? Do you kind of find yourself thinking about food frequently? Do you ever wake up in the middle of the night and feel the need to eat? And if they do, there's the question then, are you aware of it? Or, some people don't realize that they eat. And that's two different scenarios in terms of whether they're aware of it or whether it's more like a parasomnia. And it could be something that they have absolutely no kind of clue that they're doing. And then the weight history, right? So kind of how long did you feel like, when you first started struggling with your weight? Do you remember how old you were? Or when you first tried to lose weight? Or, can you tell me what your weight, was at age 18? What's been your highest adult weight? What's been your lowest adult weight? Have you had multiple times where you've lost more than 20 pounds? And, what did you do? What other attempts have you made? Likewise, kind of do you remember what was going on when you gained weight? Because most weight gain is connected to times of life stressors. So it could be, I moved or a new job or
global pandemic.
Exactly.
Thanks,
that's
COVID.
a common answer these days. For women, it's, puberty, pregnancy, and menopause, divorces, deaths, all of those. So really, really detailed in terms of that weight history and dietary history. When we think like exercise, people are like, oh, I'd ask about exercise. Yeah, that's great. You can ask about exercise, but I think more important question is, well, how much do you sit throughout the day? So what do you do for work, and how much time do you spend at work? And then do you have commutes? Do you travel? What do you kind of do in your spare time or leisure time? And then what are your restrictions, right? Like, so do you even like exercise? And if you do like it, do you have access to it? Kind of the same thing for food. Where do you grocery shop? I think that's a great question, because a lot of patients will tell you, well, the closest grocery store is, an hour away, so I use the convenience store that's close by, or, they really are kind of challenged by some of these food deserts. And then again, family history, I think, is important. Sleep history, we know that sleep is significantly impactful on weight management. And so that threshold is about 6 hours. And I think our country is very sleep deprived. And so a lot of patients really struggle with either both staying asleep or falling asleep, and kind of just this low kind of quantity of sleep as well. So what I'm looking for is that kind of 6 hour duration. Screening for sleep apnea is really important in terms of snoring. Anyone has seen you stop breathing when you sleep? Do you wake up feeling really tired even though you slept, a good 6-7 hours? And then moving on to the physical exam, there's certain key elements. Again, yes, you do your kind of typical head to toe physical exam. I think in particular, some things to highlight patients with obesity that you're looking for is not just the body mass index, but that change, right? So again, what was your weight, kind of at these different time points, to get really a picture of what their weight has done. And particularly within the past, 1, 3, 5 years. The neck circumference, really important to screen for sleep apnea. So 16 centimeters for women, 17 centimeters for men. You can kind of see when you have them open their mouth, you can see a real crowded oropharynx, and that can suggest a higher risk for sleep apnea. Acanthosis, which is kind of that hyperpigmentation along the neck, which can reflect insulin resistance, and so potentially suggest higher risk for prediabetes. Hirsutism, or hair growth for women, which can again kind of suggest excess androgens, and potentially polycystic ovarian syndrome, which has been shown to make weight management more challenging for females. Blood pressure, really important, vital. Heart rate typically tends to be elevated, particularly in patients with severe obesity, so I don't think as useful or predictive, but obviously blood pressure, because that helps you with risk assessment. Waist circumference. So I think this is actually much more telling than body mass index or weight, which I, again, don't think really tell you anything at all about health. Waist circumference will. And for most people, the easiest way is to just go around the umbilicus, and with a tape measure, kind of a normal breath, not holding it in, not kind of blowing it out, but just kind of at a normal weight, normal breath, and measure their waist circumference. And for women, when it's over 88 centimeters or 35 inches, or men over 102 centimeters or 40 inches, again, has been shown way with better kind of validity to increase their risk of cardiometabolic disease. The skin exam, and this is something that patients might not be very forthcoming. And so I tend to just ask, hey, do you ever get rashes or redness or irritation, kind of under your breasts, under your stomach, under, sometimes down in the groin, things like that. And they usually do try to treat it on their own with either different powders or deodorants or things. So assessing essentially what you're looking for is risk of Candida, which can happen when the skin folds just get kind of moist and trapped, and friction. And then also hidradenitis, which can be a really tough, which you can see on a skin exam, and can be a very debilitating disease and connected with excess weight. And then the lower extremities, because a lot of people struggle with both chronic venous stasis and then lymphedema. And there's some ways to kind of tell the difference in terms of, for chronic venous stasis, are there other signs of poor blood flow, kind of the cooler extremities or discoloration, you kind of get those pigmentation changes, you might have loss of hair, weaker pulses, things like that. So I think those kind of set a little bit different and are maybe atypical of what you'd focus on in physical exam for patients with other medical conditions. And then testing. What do I do when I see a patient? What kind of workup are we doing in clinic? Well, essentially, we're doing risk stratification. So I'm trying to assess, do they have any active, either metabolic, mechanical, psychological, degenerative, neoplastic diseases? Are there anything active? or are they at risk of any certain diseases? And so we do absolutely kind of evaluation of liver and kidneys. LFTs aren't a great predictor for non-alcoholic fatty liver disease, but sometimes they may be elevated. Typically, you're kind of assessing that more from other metabolic diseases, such as the presence of type 2 diabetes or sleep apnea. We're assessing for diabetes, so we look for insulin. We do hemoglobin A1C. We do a fasting blood glucose. We look at thyroid. We certainly look at cholesterol panels. Occasionally and quite often, I'll assess for vitamin deficiencies. B12, iron, vitamin D can be low in this population. And then often we'll also look at a CBC just to assess for any kind of anemias or things like that. We have been starting to do more. We used to do CRP to try to assess kind of like a cardiac risk factor, not as reliable. And so we don't do that as routinely. More and more, we're actually starting to test lipoprotein A at least once to kind of help assess, again, cardiovascular disease risk. Sleep studies, I probably order on my new patients. I would say 8 out of 10 is ordering sleep studies on after doing an assessment in terms of risk factors, and then certainly testing that. It's nice. They do a lot of home studies now, so it's a little bit more convenient for the patients. Abdominal ultrasounds I will do on occasion if I'm concerned about either gallbladder disease or non-alcoholic fatty liver disease. More often, if they come in with a history, I'm usually sending them, particularly if they're higher risk, for like a FibroScan or assessment by a hepatologist. We do a lot of EKGs as kind of that first step, particularly if there is any kind of history of palpitations or things like that. And then I think what we need to be really careful of, and what experts in the field and people who go into this field are, you think about ordering studies, you have to be careful to make sure that they can accommodate the patient. So for example, stress testing for patients, particularly treadmill stress tests, you want to make sure that they can meet the weight limit of the treadmill. Similarly, CTs, MRIs, you have to make sure that they can meet the weight limits of. And then echo versus, nuclear kind of studies, what's going to give you the best picture, because some of those can be harder to assess because of just the body habitus for patients. So that's kind of walks through the history and physical that I typically would do on a new patient coming into clinic.
Nice. Lots and lots of things to think about, which for a standard, like an orthopod, it's like, oh, you broke your arm. How'd you break your arm? Okay, great. Let's go. You don't need to think about all these other key things. So great.
Yeah. So I think that hopefully gives an example of what the field is like in terms of depth. Absolutely.
Yeah. Okay. If you want to come on and walk through a second case here and kind of be a guinea pig and see what it's like to be a medical student or resident and get asked questions by an attending, go ahead and raise your hand. I cleared out the deck, so we'll start bringing you into the room to be able to answer some questions.
Way less pressure than when you're getting asked while during a surgery or anything like that. So
yes. The random. I remember my ortho surgery is you prepare as best you can, and then they just come out with a question from left field.
Totally,
I'm like, what? Like, come on! I tried my best.
I remember it was just a gallbladder case, but the surgeon said the first question was if I knew who sang the first song on his playlist,
of course,
then I wouldn't have to answer any more questions for the rest of the case.
Yep.
And I nailed it. So nice. Sometimes other trivia is important too.
Yeah. Music trivia is key for the OR.
Never know.
Nobody wants to raise their hand. Everyone's scared. I cleared out everyone, and everyone is scared. So let's go ahead and start. And if people raise their hand, I'll bring them on.
Okay, sounds good. So RR is a gentleman in his late 40s, and he has class 3 obesity, so body mass index of 45. So another way is saying that severe obesity, known type 2 diabetes, known hypertension, severe osteoarthritis, who was referred by his orthopod for weight loss prior to a total knee replacement. Needs to lose 30 pounds to meet that criteria of a BMI less than 40 or less. So you get some data on him. His blood pressure is 148/98, heart heart rate's 85. His weight is 285. He does have kind of that central adiposity with an elevated waist circumference. And right now he's in a lot of pain and even using a cane for ambulation. His meds that he's taking right now, he takes the metformin 1,000 twice a day. He takes a PPI omeprazole for his GERD, 20 milligrams daily, HCTZ for blood pressure control along with an ACE, and then ibuprofen to help with that knee pain, 600 milligrams 3 times a day. And his hemoglobin A1C is last was 7.3. All the other labs are pretty unremarkable. So you get some information about kind of his current behaviors. So his diet, totally skips breakfast, kind of does his thing. He gets going, has a cup of coffee, and then really doesn't tend to eat until about 1 or 2 p.m. And it's usually something that he grabs while at work, outside of the home. Eats meats a couple times a day. His fruits and vegetable intake is pretty low. Not really soda, maybe, a few times a week. And same with alcohol, maybe 2 to 3 times per week. His activity is pretty difficult due to knee pain. So he does about 2,000 to 3,000 steps per day. And then he golfs a couple days per week, but mostly he's using the cart because walking has been so difficult for him. Sleep, he's sleeping right around, 6 hours most nights, maybe gets lucky in 7, is using his CPAP consistently. And he kind of just says the typical stressors, no acute life stressors, mood's been pretty stable, not a lot of, emotional eating, stress eating, things like that. So first recommendations for treatment. So a couple options. One, tell him to join the local Y and focus on water-based exercises to help with his knee. 2, cut his calories by about 25 to 30% daily. Tell him to just get completely rid of all alcohol and sugar-sweetened beverages for now. Start eating breakfast, or refer him for bariatric surgery. So in thinking of this with like any test, the key is in the wording. And so the first recommendation for treatment. So again, when we think about the 3 options we have, anything else you're going to do, you are always going to focus on behavior modifications. And the 4 that I think have the greatest impact on weight as of right now, eating, activity, sleep, and stress. So if we look at all those, well, stress, we said, yeah, he's not really having any major stressors, not really having issues with stress coping. Sleep was meeting that threshold. He's using a CPAP, so not too much to change right there. Eating and activity. So activity, he's got really bad knee.
2 students on with us too, if we want to ask them.
Oh, okay, sure. Before I go any more.
Yeah. Berline, I think you were the first one here. Go ahead and unmute yourself.
Hear me?
Yeah,
Hello?
you. Hi.
Yeah.
Okay, sorry. It's Berlin.
Berlin.
The question that I have. Oh, I also purchased your book.
Well, no. This isn't for asking questions. This is for participating in this case. Do you have an answer for this case?
Yes, I have something for the case.
All right.
I had a question with the first case.
Nope, this isn't about this case. All right, we'll move on. McCaden, what is your thought on this case?
I missed a good portion of it, but
okay,
just from context clues.
The question's right in front of you.
I can't see it for some reason.
Okay.
But it sounded like he wasn't eating breakfast, right?
Yep.
And I mean, if we're trying to start small, I feel like that's something that would be smaller. A small step is starting to eat breakfast and see how he feels after he eats breakfast. And then, test it a couple weeks and then see maybe, last resort, I would assume is surgery. And cutting out sugary beverages is, going cold turkey is really hard. So I don't think it's that at all. And, usually trying to wean people off is a lot better than trying to just jump into something. So I think having him start with breakfast and then take smaller steps from there would probably be the best path based on what I heard.
So I actually love your answer. And had it been, a couple of years ago, we probably would have been dead on. So this is where it gets a little bit more complex. And when we look at people who are maintaining weight loss, and one of the best resources for that is the National Weight Control Registry. And we assess, okay, these are people that are high achievers with weight loss. They've maintained it for long periods of time. What are they doing? One of the top things they do is they eat breakfast. So you picked up on that he skips meals, and that is excellent. The caveat to that is the way that this is just start eating breakfast, right? So if the answer had been something like, oh, start doing maybe like a protein shake for breakfast, or doing a Greek yogurt, or, doing something low calorie, high protein, I absolutely would say that's your answer is legit. The problem with this is why this has been debunked, is we've often said people need to eat breakfast, but a couple things have proven that wrong. One is because the idea is, well, what are they eating for breakfast? I have plenty of patients that eat breakfast every day, but it's a biscuit, from Biscuitville, a sausage biscuit, or it's, cereal kind of full of sugar, that type of thing that could actually be detrimental to weight management. And the other concern is that, or not concern, but the other thing is that now we're seeing some data out of time-restricted feeding, right? Where people who may not start eating until later in the day, and they have smaller feeding windows and longer fasting windows, they may have some success with weight management. So I would say good answer, but the actual answer is B. And this is kind of the traditional conventional treatment, meaning whenever you have a patient to put them in an energy deficit for weight loss, we're trying to cut that by about 30%, which usually equates to either 1,200, 1,500 calories for women, or 1,500 to 1,800 calories for men, depending on kind of height, age, those kind of things. And then for active weight loss, we do say get rid of all alcohol. But you're exactly right. Point about the soda. For all my patients that drink soda, I always do say, let's wean it over the first 2 to 3 weeks of treatment. So you made some really good points. But the main part of this is that you want to put them in an energy deficit, and the idea of it's not just the eating breakfast that seems to help with weight management. It's really the structure of the eating pattern, nothing specific to breakfast. Does that make sense?
Nice. Thanks, McKaden.
Okay. So this is just, I have no idea kind of people's amount of exposure to weight loss medication. Most of the fourth year students I work with, and med students, have had very little exposure to weight loss medication. So I thought I'd just throw that out there, just out of more curiosity of if there'd be anyone to volunteer and answer.
Joshua, you're on the clock, man.
So what would be an appropriate medication to begin for him for weight loss? So your options are A, low dose phentermine. So phentermine is the most kind of widely prescribed medication for weight loss. It is a stimulant, and some of its side effects can be increased blood pressure, increased heart rate, sleep disruptions, irritability.
Is that half of the wonderful fen-phen that we had back in the day?
It was. The fen-phen was phentermine, fenfluramine, and fenfluramine was pulled from the market, although it's recently been approved for use in childhood epilepsy, which is interesting, but was pulled from the market because of concerns for valvular disease, valvular heart disease, and pulmonary hypertension. Phentermine has never been proven to have any severe cardiotoxicity in patients without severe cardiac toxicity or cardiac issues. So, but it does have side effects because, again, of that stimulant kind of mechanism. It works to increase your sympathetic nervous system, essentially. So blood pressure goes up, heart rate can goes up, again, sleep disruptions, irritability. There is a weight loss medication that's FDA approved called Qsymia, and that's the brand name. And it's a combination of phentermine, low dose phentermine, with Topamax pyramate. And we know that these two together seem to have an increased effect on weight loss. They work in different parts of the brain. Topamax can cause dry mouth, metallic taste, tingling in fingers and toes, kidney stones, but for the most part, pretty well tolerated for a lot of patients. You could consider Topamax by itself, but that is not FDA approved as monotherapy, or liraglutide, 3 milligrams, which is brand name is Saxenda, and this is one of our newer weight loss medications that FDA approved. It's an injectable, and it's also at a lower dose used to treat type 2 diabetes. So going back to this guy, I'll just put his numbers up and that might take a while. Let's see.
It's fine. I can't see it anyway.
Okay.
That's weird.
Is no one else seeing it?
No, yeah, other people can see. For some reason, the people that join. Because everyone is chiming in.
I'm just going to base it off of those notes.
Oh, okay. Okay.
The tone of your voice makes me think that A is not the answer. The reasons that make me think that is because it looked like he already had high blood pressure and he was on the line of like sleep. He was getting 6 hours of sleep, so if he's getting less sleep, that's probably just going to counteract the issue. I'm a little unclear. It sounds like B would have the same side effects, or does Topamax remove the effects?
Perfect.
Okay,
Yep.
so then B has the same side effects. C, I happen to somewhat be an FDA lawyer, so I feel like giving him an unapproved drug wouldn't be a good idea, unless it has already been approved for something else.
So so good question, and it has. So that's where the kind of complexities get into it. But yes, agreed. If we go strictly by the FDA, it is not FDA approved for weight loss as monotherapy.
Yeah, so it have to be off-label. Joshua, the FDA lawyer in here. Okay,
No,
all right.
I
Just play
I don't
one
know
on
that
TV.
many laws. So then we're left with D, the raglutide injectable.
Yeah.
So
So that's great. So that was the main point of this question, is exactly for patients with high blood pressure, because again, phentermine is going to be the most common. It's actually going to be the cheapest option for a lot of patients in terms of weight management, and it's effective. So I don't want to kind of, say, oh, it's not appropriate. It's absolutely an appropriate weight loss medication, but the blood pressure has to be controlled first. So if that was his only option in terms of, cost and tolerance and things like that, then I would have to get his blood pressure under better control and then start the phentermine. So that nixes phentermine, that nixes the phentermine to pyramate combination. To pyramate, there is some data and definitely some nice, kind of observational retrospective studies that have shown it to be beneficial. Night eating, there's some particular interest, binge eating, but it is not by itself FDA approved. It's approved for migraines, bipolar, seizure disorders. So it would be off-label use. And so for purposes of education, obviously I wouldn't want you to go use an off-label unless you are becoming an expert in the field and have the conversation with the patient and go through all the appropriate steps. So then we have liraglutide, and that is the answer. And it is the new GLP-1 analogs are showing to be incredibly effective with weight management. And that's the newest one that was approved this summer, semaglutide. So liraglutide at a low dose, it's approved for type 2 diabetes treatment. At a higher dose, it's approved for weight management. The liraglutide is a once a day dosing. The semaglutide is once a week dosing. So this one on average has shown about 11% weight loss. The semaglutide on average is showing about 15% weight loss. So just really exciting for our patients to have these more powerful tools and much, better treatment to help them kind of ability to reach the weight loss goals, and then again, improve health, reduce disease risk, things like that.
I have a quick
how are we doing?
about D.
Yeah.
So I know that costs weren't part of the question, but like daily injection sounds expensive.
Yeah.
So would there be a world where you just go, let's try to get your blood pressure down and then get you on something cheaper?
Yeah. Absolutely. So great question. And you're exactly right. And that's one of the other, again, I think biases in some of the weight loss medications is the coverage and access to them in terms of not just being prescribed them, but then being able to actually afford them and having health insurances that cover them. So Medicare, Medicaid, right? Some of our most vulnerable populations do not have any coverage for weight loss medications. Private insurances, commercial insurances, market insurances are all iffy. And so, for example, here in North Carolina, there's a plan that's out by Blue Cross Blue Shield that has stopped covering all weight loss medications. So think about if they had done that to another class of medications, right? Anti-blood pressure, antihypertensives, anti-diabetes meds. I think this is where some of the bias comes in. Regardless, cost is a very important, and so I'm glad you brought that up. And should that have been too expensive, you're exactly right. That would have been my approach. I would have said, look, I think you still have some options, but we got to get that blood pressure under control, and then that opens up some of these other ones that we could potentially use. So great follow-up question.
Thanks, Joshua. We're out of time. That went
I just saw.
Yeah, it's interesting. The whole pharmaceutical, and Joshua made a great point about cost. It's disgusting, the cost of new medications coming out from the pharmaceutical companies. It's ridiculous, and I don't blame. I mean, I hate private insurance, but I don't blame them for not covering it. Because they're charging an arm and a leg for stuff that is pennies to develop to make.
Right.
And their marketing dollars are going through the roof, and their chief executive compensations are going through the roof. Oh, it's hard. It's hard.
Yeah, I know.
And
Right?
I have
mean,
a wife
it
who
is.
works in the pharma industry, so I got to bite my tongue a little bit, but.
But no, you're right. It's almost like it's the two, clashing, and everyone's winning, but the patient. So
Exactly.
It gets very frustrating. Yeah.
Yeah, exactly. Yeah. I have a daughter who has a condition. She wasn't eligible because of her age for the most expensive drug ever at $2.1 million for a one-time treatment for Zolgensma. I don't know how familiar you are with that. Yeah. 2.1. Her second prize is $375,000 a year is the cost of her medication.
I mean,
but
what do you do with that?
What do you do? It's a life-changing drug. What do? You pay it. Figure out a way to get it.
Wow.
Well, this was a fascinating discussion. We could have gone on for a while, and I think just it leads to, I think, the fact that we led with is obesity and weight are integral to everything that we do as humans, exercise, diet, our lifestyle, and everything we treat as physicians. So it leads to lots of fun discussions.
Well said. Yeah, absolutely.
So thank you for coming on and sharing your wisdom. Maybe we'll bring you on in the future at some point again.
Sounds good. Appreciate the opportunity.
Yeah. Everyone have a wonderful night.